My name is Dr.Socinski. I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I am a thoracic medical oncologist, and I'm a member of the Institute's thoracic oncology program, actively seeing a large volume of lung cancer patients, as well as continuing many clinical investigations in the thoracic malignancy space. The first discussion will be around how to manage patients with stage 3 unresectable non-small cell lung cancer who have a poor performance status. We know that almost all of the clinical trials historically establishing the current standard of care have been done in ECOG PS0 to 1. That standard of care today is concurrent chemoradiotherapy, plus or minus induction, followed by consolidation immunotherapy based upon the PACIFIC trial. We've seen mature long-term survival now out to 4 years. We expect to see 5-year survival in the very near future, showing a clear benefit in overall cure rates or 5-year survival rates with the addition of 12 months of immunotherapy. The question is, how do we extrapolate that to patients that would fall into this category of poor performance status? And by poor performance status, I would largely focus on the ECOG performance status 2. And sometimes what I refer to as an ECOG performance status of 2.5, which means they're a little worse than 2, but they aren't completely clearly ECOG 3. You know, part of the assessment we go through is, what do we think the poor performance status is due to? Is it due to the disease? Is it a very large volume of disease? A large volume of disease may bring with it some considerations of the size of the radiation field and some concerns from the radiation oncologist about, just what the risk may be there in a very large volume field. Sometimes the comorbidities are due, the poor performance status is due to comorbidities. Patients, obviously, the majority of lung cancer patients have some smoking history, smoking in aging, since the median age of lung cancer is now 70 to 71. Smoking and aging brings with it comorbidities, cardiac, pulmonary, other diseases that come along with it. So often when you talk to patients, you realize that even 2 or 3 years prior to them being diagnosed with lung cancer, they were a PS2 at that point, largely because of their comorbidities. And there's a lot of art in this area, in the sense that, we like to think that we customize treatment in those patients in which the disease we think is driving the performance status. You have to be worried that maybe you're missing a occult stage 4 disease. And I mentioned before about the issue of bulky intrathoracic disease and some of the radiation concerns that may be there, particularly in patients who have a poor baseline pulmonary function. We often will give 2 to 3 cycles of chemotherapy by itself. And sometimes if the patient responds and you see a response, their performance status may improve because it was really the cancer that was driving the performance status. And then we may embark on a subsequent concurrent approach. So an induction as kind of a stress test for the patient to see if they do improve and respond. Also, part of that stress test is if they don't respond or if they progress. If you then determine that they really had occult stage 4 disease, you may find other disease at the time of restaging after 2 to 3, maybe 4 cycles, in which you wouldn't then pursue a concurrent chemoradiotherapy, because remember, concurrent chemoradiotherapy does have toxicity, particularly esophageal toxicity, that can be pretty tough with a large radiation field volume. In the patients where poor performance status is driven by comorbidities, we at least tend to be a bit more conservative, because obviously the whatever strategy you take, chemo by itself, chemoradiation, sequential chemoradiation, is not going to improve the comorbidities. And so you wouldn't expect that patient to necessarily improve. So in the issue where we think there's a lot of comorbidities, we tend to be a bit more conservative and less aggressive in our approach than the aforementioned patient in which we think the disease is driving the disease. or the performance status. So I think that those are some generalities about the PS2 population. I think you have to individualize. I think you also need to talk to patients about patient preferences in terms of what their goals are of treatment. In good performance status stage 3, I always tell patients the goal is cure, long-term survival. Sometimes in these very poor performance status, particularly those patients where the PS you feel is driven by comorbidities, it may be a much more conservative goal, but you have to explore patient preferences in that setting. So that's kind of a general overview of how I think about the PS2 population.